invite Dr. Santosh HONAVAR, who is clearly heading this particular show. He is General Secretary of All India Ophthalmological Society, man behind this mega event. And also we all know about his academic credential. He is the Indian face in ocular oncology all over the world now. So we look forward to hear Dr. Santosh Honavar on plaque brachytherapy. Dr. Honavar, please.
Thank you, Mukesh. I'll be speaking on plaque brachytherapy as we know it today. Brachy is short, such as brachycephaly, whereas tele is long. So you deliver radiation from a short distance or proximal to the tumor, then that is called brachytherapy. There are many devices, and plaque being just one of the devices that's used for brachytherapy. It provides very high dose radiation as is appropriate for the treatment of the tumor, precisely and selectively to the tumor without any collateral damage to the retina in certain cases, to the orbit, to the brain, etc. With selective dose distribution, you can customize dose distribution to the optic nerve in a juxtapapillary tumor, for example, thus reducing radiation-related complications. There are many isotopes that can be used, one of which is ruthenium, which is very popular in India because of the logistics that are involved are easier. Ruthenium comes in various shapes and sizes. That's an added advantage. There are many tumors starting from the ocular surface to the retina uvea that can be treated with brachytherapy. When you assess a tumor, you need three parameters: location of the tumor, basal diameter of the tumor, and the height of the tumor. Location is always relative to vital structures such as optic nerve, fovea, macula, etc. Then you do a large digital photograph, and drawing is essential because more than a digital photograph, you can actually demarcate the tumor and mention the clock hours in a drawing. So retinal drawing is mandatory if you're treating a uveal retinal tumor. Then you input these parameters into a brachytherapy software, which is a dosimetry software. Select the plaque that you plan to use and its shape. Then you prescribe the required dose to the apex. That's called tumor apex dose. In retinoblastoma, it may be 4,500 centigrade. In melanoma, it can be 8,000 to 10,000 centigrade, and so on. Required dose is prescribed to the apex, and at the same time, you calculate the dose to the base so that you don't have complications such as scleral melt. Then a 3D automated conformal dosimetry software takes over. It gives you the dose and the exposure time. It also tells you about the plaque placement if you have inputted the axial length and the corneal diameter into the software. And that is the kind of isodose curves that the radiation oncologist or a physicist is going to give us, with which you know the dose to the lens, and you can predict the onset of a cataract, at what portion of the lens would the cataract be if it is selective, and pre-warn the patient that, okay, you're going to develop cataract, you have a higher chance of developing radiation retinopathy, you have a higher chance of developing radiation papillopathy, etc. Also, because of the notch design, you can fix the dose to the optic nerve and also predict the onset of radiation-induced optic neuropathy, which can be acute, and pre-treat this patient with steroids to prevent that, or optic atrophy. Plaque placement is generally done under local anesthesia unless it's a child. You start with a conjunctival peritomy, locate the tumor, mark it on the sclera, use a dummy plaque to confirm the location, then the hot plaque is placed and sutured to the sclera, and finally the surgery is completed by closure of the conjunctiva. It's a very simple, straightforward surgery, but what is most important is localization. However sophisticated may be your software, if you haven't localized the tumor intraoperatively and placed it at the right position, you will be totally off track because you just have a 2 millimeter window on either side of the tumor. That is how we mark the location of the plaque, place that silicon dummy plaque, and further confirm the location by using transscleral helium neon laser, which you can visualize using an indirect ophthalmoscope, confirm the location of the tumor, and then place the plaque. This is the dose that we give, 8,000 to 10,000 centigrade for uveal melanoma. Choroidal hemangioma gets a lower dose of about 3,000 centigrade. Retinoblastoma gets around 4,500, and ocular surface squamous neoplasia about 6,000. The effect of plaque comes very slowly. This was a ciliary body tumor with iris extension. You can see that after about 12 months, the tumor has reduced in size, and it will never be a flat scar in uveal melanoma. It will always remain a small, stable scar. So that is the final outcome. So you'll never see the tumor disappear in uveal melanoma. It will become smaller, whereas in OSSN and retinoblastoma, the tumor generally disappears. This Vishal is familiar with this patient. This patient presented with ciliary body melanoma with iris extension with hyphema, and following plaque brachytherapy, the tumor completely went away. That means that it was a poorly differentiated tumor. That happens only in poorly differentiated tumor. Otherwise, these are the typical outcomes. That's a choroidal melanoma treated with brachytherapy. You can see some effects of radiation retinopathy right in there. Now we use preventive measures such as intravitreal ranibizumab 4 times over 1 year to prevent the complication of radiation retinopathy. Amelanotic melanoma, good outcome. Juxtapapillary tumor, you can see that there is inferior optic atrophy. Choroidal hemangioma, diffuse choroidal hemangioma, retinoblastoma, you can see that the scar has become much smaller and macula is open. That's a very good effect of brachytherapy on retinoblastoma, where chemotherapy was contraindicated, so we had to resort to plaque brachytherapy. You can see nice pink and healthy optic nerve, indicating that there is no optic neuropathy at all because of well-planned radiation and use of a notch plaque. In ocular surface tumors, the oncological principle is that we have to have edge and base clearance. While edge is easy to determine, you can see it on slit lamp, the base is opaque, you cannot see through the tumor. And although there might be some clinical parameters such as moving the tumor with a wet cotton tip applicator under slit lamp evaluation can give you some idea about the base, but the real test is using a OCT or UBM to look at the base, and that fortunately correlates with histopathology. You can see in this patient that this is the normal corneal stroma, this is hyperreflective splayed corneal stroma indicating stromal invasion already. This patient cannot be treated with excision alone. Either the patient would need a penetrating keratoplasty or plaque brachytherapy. This is how OCT correlates with histopathology, and that is very good for us. So what if sclera and cornea are involved, or there is intraocular extension in OSSN or melanoma, or what if on excision you find the base is positive? These are clearly beyond surgery. And earlier we were resorting to extended enucleation or exentration in these patients, but no longer so. Primary plaque brachytherapy is when you don't excise the tumor completely, such as in this patient where there is corneal stromal melt and scleral melt. When if you try to excise, you'll be interfering with the tectonic integrity of the eye. This gaping hole in the sclera is impossible to repair. So here you do a small biopsy at a safe zone, confirm the diagnosis if you have any diagnostic dilemma at all, and then do brachytherapy right on top of the tumor. This is one situation of doing plaque brachytherapy. Second situation of primary plaque brachytherapy, when the imaging, MRI, UBM, or OCT has unequivocally confirmed the involvement of corneal stroma, sclera, or extraocular muscle insertion, or intraocular extension has been confirmed, then again you do primary plaque brachytherapy. In both cases, the results are very good. This is the same patient after about 3 months. Secondary plaque brachytherapy is when you're not sure of the base extent. You excise as per the protocol without doing lamellar sclerectomy or keratectomy, confirm the base involvement on histopathology, followed by brachytherapy. This fits into our adjuvant treatment protocol, which is histopathology based. So if resection base is positive and it is diffusely involved, the option of treatment is plaque brachytherapy, that is for sure, and that is exactly what we follow in these patients. This is secondary plaque brachytherapy. You can see nice results, and the sclera is white, avascular, but tectonically very strong. Generally does not melt. Scleral melt is an extremely rare complication. Even after 5 years of follow-up, you find the sclera remaining the same. This was a diffuse melanoma. The patient's other eye was traumatized, so he had poor vision in that eye. This is the only seeing eye, 6/6 and 6 vision with diffuse multifocal melanoma, recurrent after 2 surgeries elsewhere, base not being taken care of earlier. Unfortunately, this patient also had limited ciliary body extension. So how do we treat those patients? Obviously, extended enucleation was a choice, but if you want to save vision, we had to excise it and treat with what is called a rotational plaque brachytherapy, where the entire base of the tumor was covered by plaque placement sequentially, and finally the patient did well. The results of some of these techniques have been published already. This was a melanoma with scleral invasion, huge melanoma. The nodular component is not to worry about. The scleral component is something that we worry, and that was taken care of by plaque brachytherapy. Life salvage is nearly 100% in these patients, except uveal melanoma, where the life salvage cannot be determined by plaque brachytherapy or enucleation. That irrespective of that, they have a risk to life. Tumor outcome is spectacular. Vision salvage depends on the location of the tumor. In melanoma, we have suboptimal vision. In all other tumors, the vision salvage is very good. The barriers so far were cost of brachytherapy sources and the simulation software, all of which were imported. But with the Make in India plaque by BARC, with who we collaborated, there are many designs that are available. We are currently working on newer designs to optimize the dose and delivery of plaque brachytherapy. With this, we have got much better success. Thank you so much.
Thank you, Dr. Honavar. Amazing talk as usual, and it's based on extensive work and meticulous follow-up. I'll request you to stay back for maybe 10 minutes or so that we can have some questions.